Hi, this is Ron Broussard, and today we'll talk about Chapter 30, Musculoskeletal Trauma. Now, in review of the musculoskeletal system, we have our basic functions, which it gives our body its shape, protects the internal organs, which of course is necessary, that protection for the ribs, protecting the heart, the lungs, the skull, protecting the brain. If we didn't have that protection, even the lightest trauma could cause significant damage. Helps provide movement, stores salts, other minerals, and then produces red blood cells, which producing of red blood cells actually occurs in the bone marrow itself. Now, we have three types of muscle. We have skeletal muscle, which is voluntary, meaning you have control over it. I want to move my arm moves. Okay, it allows me to walk, allows me to pick things up, allows all that movement. So, big thing with skeletal muscle is it's voluntary. You have control over it. Okay, and then you have your smooth muscle, which is involuntary, meaning it works with the autonomic nervous system. You don't have to think about carrying out these functions, they just do it themselves, such as the small intestines or your large intestines. Okay, you don't have to think about peristalsis, which is that smooth muscle contraction that moves, your broken down food through the GI tract. You don't have to think about that. It's in your blood vessels. You don't have to think about constricting blood vessels or dilating blood vessels. Your body just naturally does that to accommodate for blood pressure. Okay, and then we have cardiac muscle, okay, which is found in the heart. Now, cardiac muscle is very specialized in that it runs on automaticity. It does not rely on stimulus from the brain. While it can be stimulated by the brain to adjust its heart rate, like, if you get a fight or flight, that can send messages to the brain to increase heart rate. It can function without it. It works on its own primary pacemaker site called the sinoatrial node. So even if, like, you've probably seen it on TV where they can remove the heart and the heart's still beating, that is true as long as it gets a good supply of oxygen and glucose and those nutrients to those heart cells, it's going to continue to pump. So the heart is specialized, it runs on automaticity. Okay, we have tendons and ligaments. Now, tendons connect muscle to bone, ligaments connect bone to bone. Now, remember this. This is going to be something that you'll see come up on tests. So, tendons are going to connect those muscles to the bone itself that it will articulate with, and then ligaments connect bone to bone. All right, and then you have your cartilage. Now, all cartilage is an extension of a bone end. So it's made up of connective tissue. Now, what it does is it allows for you to have smooth movement at a joint site. All right, now patients who have arthritis, the issue there is arthritis is inflammation of a joint, but you also see degradation of the cartilage. And so you end up with a bone on bone contact there, and that is extremely painful. And it's not going to be nice and smooth, so there's more friction at that joint site. All right, here's your example ligaments connecting bone to bone, and then your tendons connecting muscle to bone. All right, this is your basic overview of a joint itself. So you have the long bone itself, what you're seeing here. Now the extension of connective tissue that makes up the cartilage. At the end of the bone head there, you have the joint cavity, which is filled with a synovial type fluid, which helps with lubrication. Uh, and that's going to make up your joint site. A lot of times when people have injuries to joints, there's a lot of inflammation, and that inflammation is what causes pain and that limited movement. Okay, now with the skeletal system, we have 6 types of motion. Okay, you have flexion. Flexion in and of itself is just decreasing the angle of the joint. So it's hard for me to show you guys just through this, but with flexion, if you could think like somebody flexing their bicep, what are they doing? They're pulling that arm in, and they're decreasing the angle of the joint at the elbow. So that angle area is getting smaller. Extension is think of somebody extending their arm out at the elbow joint. Now what you have is an increase in the angle of the joint side. Okay, so flexion, we're decreasing the angle. Extension, we're increasing the angle. Okay, adduction is movement toward midline. Okay, movement toward midline. Abduction is movement away from midline. So a nice way to think about this is adduction, you're adding to the core. Okay, so movement toward midline. Okay, abduction, aliens abduct people, they take them away. Abduction is movement away from midline. Okay, rotation is as simple as you think. It's rotation at a joint site. Circumduction is a combination of motions. Okay, so you have flexion, extension, abduction, adduction, and rotation. A good example of circumduction and a joint that this occurs at is at the shoulder, and you could think of it like a swimmer's crawl stroke or a freestyle stroke where you have a combination of movements. Okay, that will be circumduction. All right, now we have the skeletal system. You have the axial skeleton and the appendicular skeletal system. So the axial skeleton is composed of the head, thorax, vertebral column. The appendicular skeletal system is made of the extremities, the shoulder girdle, and the pelvis. Okay, the shoulder girdle, what we're talking about here is the clavicle and scapula. Okay, that's the shoulder girdle. So when you're thinking about this and we have you guys holding axial stabilization, I'll go, what is that? What is axial stabilization? Well, you are holding the head and the body, specifically the vertebrae, in a nice straight line, trying to stabilize that. Well, it's because we're trying to stabilize the axial skeleton. So axial skeleton, head, thorax, and the vertebral column. You guys may see a question on a test just along the lines of, the femur is part of, which skeletal system, or reverse that is of the following bones, which one of these is in the appendicular skeletal system? So like the femur, the ribs, vertebrae, the skull, okay, well, the femur would be part of the appendicular skeletal system. All right, now just gross overview here of the skeletal system. This is not the anatomy class that you guys got at the beginning. You guys should at this point know your bones, okay, at least be somewhat confident in your bones, giving you an idea of kind of where they're at, what they're called. Again, this is just a little bit of an overview, and we'll move forward. Okay, now bones of the upper extremities. So clavicle here, scapula in the back. Now remember that makes up your shoulder girdle. Humerus is the upper long bone in the arm. Radius is on the thumb side. Ulna is on the side of the pinky. Okay, carpal bones are the small bones that make up the hands. Metacarpals are the longer bones, and the phalanges are the fingers. All right, now lower extremities. With this, okay, you guys should be comfortable with, again, the bones. Now, we really don't go like that deep into bones. Like, you don't need to know that the small bones, the small carpal bones, the name of them, which there are names for them. And the same thing with the tarsal bones. There are smaller bones that are in there that each have unique names. But you guys should have a good idea of the gross overview. Like, I should understand the pelvis, and then the three separate bones that make up the pelvis I should be comfortable with. Okay, so you have the ilium, okay, which is kind of the wings of the pelvis here. You have the ischium, okay, which is the lower aspect of the pelvis here. And then you have the symphysis pubis, which is this anterior portion here. Okay, so you guys should have a good idea of those three bones. Okay, and then of course the femur, the greater trochanter, which is this bony prominence off of the proximal end of the femur. Okay, moving down the patella is the kneecap. You have the tibia, which is the large long bone in the lower leg, and then they have the fibula, which is the smaller long bone in the lower leg. Understand the tibia is more your weight-bearing bone. The fibula is not. Uh, there's perfect examples of sports athletes that are out there. Donovan McNabb was a popular one that broke his fibula and continued to play football, continued to run. Now, was he as effective? Probably not. But that just goes to show that the fibula is not weight-bearing bone. The tibia is the primary weight-bearing bone of the lower extremity, in the lower leg. Okay, the femur is the big, massive one there, but in the lower portion of the leg, the tibia is the weight-bearing one. Okay, you have the tarsals, which make up the small bones. One tarsal bone that they do talk about in the anatomy class, and you guys should probably remember it just in case you see it, is the calcaneus bone or the heel bone. Okay, and then you have the metatarsals, which are the longer bones that branch off of the tarsals, and then the phalanges are the toes. Okay, now in dealing with fractures, a fracture is a break in the continuity of a bone. Fractures can be open or closed. Your textbook does not define it as, compound fractures. It is simple as open fractures or closed fractures. Open fracture simply means the bone has protruded through the skin. A closed fracture means that the skin outside is still intact. Now, displacement of bones can cause damage to the surrounding tissues. Bones do not break smooth, they don't break soft, they break very sharp, and they break jagged. So when you have those bone ends that are broken, moving around, that are not stabilized, that can cause a significant amount of trauma to surrounding tissue like blood vessels, nerves, and muscles. Okay? Osteoporosis is a degenerative bone disorder. Now, with this, it's the bone in of itself becomes porous and brittle. Okay, things that people can do is make sure they have adequate vitamins and minerals, things like calcium, and then believe it or not, walking and weight training exercises are great to help reduce the risk factors for osteoporosis. Now, with fractures and signs and symptoms, you have pain, tenderness, deformity and discoloration, paresthesia and anesthesia. So paresthesia is just kind of that pins and needles type feeling. Anesthesia is like loss of sensation or no feeling at all. Paresis or paralysis. So they're not able to move the extremity, and then decreased pulses and perfusion. Now, decreased pulses and perfusion, and when we have loss of sensation, these are times where we can actually realign a fractured extremity, i.e., return it to anatomical position to help promote that blood flow or to help return nervous system, motor sensory function to that extremity. Now, we have different types of fractures. So, comminuted fractures are ones where they're broken in multiple places. Impacted fractures are fractures that occur from pressure on both ends of the joint site kind of going into one another. So, like, say somebody's falling from a height, okay, and then you have kind of pressure going downward, pressure going upward. We get the fracture there in the middle. You have a green stick fracture. Now, with green stick fractures, this is going to also be one to kind of keep in your mind. Green stick fractures are very common in children. Very common in children. Children have more collagen in their bones than adults, so they have a little bit more give. It's called a green stick fracture because if you've ever gone out and like pulled a branch off a tree that's still, got a lot of moisture in it, and you try to break it, it doesn't snap. What does it do? It splinters on one side and bends. So again, green stick fractures, you see splintering on one side and maybe some movement. Now, important thing to note is you might not have any instability if you go to assess this. Now you have an oblique fracture, so just a diagonal fracture going through the long bone. You have a spiral fracture, which is caused from a twisting force. And then you have a transverse fracture, which is just simply a horizontally straight across fracture. And then we kind of hit on this one already, open and closed fractures. So closed fractures, the skin on top of the fracture is still intact. Open fractures, the skin covering the bone is compromised, like from the bone protruding through it. The one thing with open fractures, guys, is we never want to return the bone into the skin intentionally. Okay, so understand that that's not something that the bone's protruding out. You never want to try to push that back in. High risk for infection there, so we don't want to do that. Okay, so here's an example of a closed fracture. Okay, closed fracture, so it's skin on top still intact. Okay, open fracture, so obviously the skin on top is no longer intact. This is a foot. All right, it looks like the tibia coming through there. So open fracture. All right, so this is a closed fracture, no deformity to the arm there. Now, with fractures, we do have some complications, hemorrhaging being one of them, especially if it's from a proximal long bone, specifically the femurs. Okay, if it's from the pelvis, we can lose a significant amount of blood from the bones themselves. So there is a concern there for blood loss. Now, not only that, but we're worried about now a bone breaks and we don't provide stability to that bone site, and now you have these broken bone ends moving around. That can sever blood vessels, which can cause more bleeding. Hey, we have tissue damage, nerve damage, and blood vessel damage. We have infection, case, i.e. like from an open fracture. I'll use another football example here. Alex Smith, who's a quarterback for the Washington football team, he had a pretty nasty tibia and fibula fracture. It was an open fracture. Now, his recovery was hard, but what made it even worse was he got a really bad infection that almost caused him to lose his leg and even his life. So those open fractures can be very, very dangerous. And then we have interruption of blood supply. If you remember back from that previous slide of that deformed arm, well, if a bone breaks, it could put pressure on a large artery that is perfusing an area, and that area could become hypoxic, and we don't have adequate blood flow, and we can have cell death from that. Also, swelling that accompanies fractures can cause a condition called compartment syndrome, and that can also interrupt blood supply. All right, now when dealing with a strain, we're talking about tear in a muscle. Now, there are different grades of strains. You do not need to worry about the different grades, but just understand that we have a tear in a muscle. All right. Now, could be microscopic, could be tear completely through. Okay, but with this, pain is localized, and usually don't see significant swelling or discoloration to that area. All right, it is painful. People are sore. Anytime you've worked out, you've been really sore. I guarantee you probably had some small micro tears in those muscles. But you don't see a significant amount of swelling, and you don't see like any bruising or discoloration of the skin. Now, a sprain is damage to ligaments, okay, at a joint site. Now, these are also going to be, small tears of those ligaments. With that, we see swelling and we do see discoloration. All right. So strain, muscle, sprain, ligaments. All right, now dislocations. Dislocation is a displacement of a bone from the joint that it's in. Okay, with this, like a dislocation, it can cause damage to blood vessels and nerves. Those of you guys who watch and you see people put their shoulder back in after they're dislocated, that's actually dangerous, and they can pinch nerves and cause significant damage to themselves by doing that. That's one reason why in EMS, if we have a dislocation, we're not going to attempt to, in the field, reset a dislocated joint. Okay, the most common dislocation that we see is going to be at the shoulder. It's also the most mobile joint that we have. Okay, ligaments or joint capsule likely damaged. Okay, we have dislocation of the knee. All right, so click on the injury that is characterized by overstretching and tearing of muscle fibers. So we're talking about muscle fibers. Sprains talking about ligaments. Remember, dislocation is separation from a bone from its joint. Fracture is a break in the continuity of a bone. So leaves our strain, which is dealing with tearing of muscle fibers. All right, so some of our injury considerations with injuries to bones and joints. Uh, At the end of the day, we do not have an app on a phone yet that can scan an area that's injured and determine, oh, that's a sprain, that's a strain, that's a fracture, that's this. I mean, some of them, yeah, some of them will speak for themselves. Okay, but at the end of the day, if we come up and we see, bruising, swelling to an area, we're going to treat them all relatively the same because they do all share a lot of the same signs and symptoms. Now, the force that causes a musculoskeletal injury can cause other injuries. What we're talking about here is you do not want to be distracted by like an open tib fib fracture, which again, when you see one, that can be very distracting. You can pull away from like, well, the patient's breathing, but you don't realize is that they're breathing super shallow and it's not adequate. But you're so sucked into that tib fib fracture that you're not paying attention to that life-threatening injury that the patient has that's affecting its breathing. So don't get so sucked into a lot of the musculoskeletal injuries. Make sure you're assessing your life threats first. Now, always assess the mechanism of injury and the signs and symptoms. So assess what you're seeing, assess your patient. Now, with your mechanism of injury, we have direct force. So the injury occurs at the point of impact. Okay, so if you think about this, there's another sport example, Anderson Silva, who threw like that round kick and just caught the guy at the wrong spot. You have that direct force on his tibia, and from that direct force at that site, it caused the fracture of his tibia. Okay, indirect force. Injury impacts one end of the limb, causing injury some distance away. This is again going back into Alex Smith's injury. Like he did not have anybody charge in and hit his leg. What he had was somebody come down on top of him, and you had all that weight. And just with the way that weight was distributed and going onto the ground, it caused his tibia to snap. Okay, and then you have twisting force, which is part of the extremity remains stationary while the rest twist. And then from that, we can get those spiral type fractures. Now, with our critical fractures, that's where we're talking about the proximal long bones, specifically the femur, and then also the pelvis. So you can lose a significant amount of blood volume from a broken femur, up to 1,500 milliliters of blood. All right, so if you have bilateral femur fractures, it's up to 3,000 milliliters of blood. I'm about 180 pounds. I can tell you I have about 5,600 milliliters of blood. So I can lose over half my blood volume from broken femurs. Okay, a broken pelvis can bleed 15 to 2,000 milliliters of blood. So there's a significant amount of blood loss that can occur. Bones, again, they're living tissue and they have their own blood supply. Okay, so when we have injury to a bone, okay, we can expect to have some bleeding, especially with those, large proximal long bones. That is a large concern. Now, so with our assessment-based approach, all right, with long bone, joint and bone injuries in general, a lot of this stuff is going to get treated in your secondary assessment. meaning your primary assessment, you're addressing those life threats, your ABCs, massive hemorrhaging. That's what I'm worried about. It's in my secondary assessment. All right, now I'm going to go through and now I'm going to inspect. I'm going to palpate. I'm looking for my decap BLS stick. Okay. And that's where I'm going to find things, okay, in my secondary. And that's when, if there's time, I can work to splint those fractures. All right. If there's not time, well, I'll deal with it on the way to the hospital, okay, if I have a critical patient that has other life threats going on. Okay. So a fracture may be suspected in the field by signs. Okay, some of them, of course, may be opposite. If you have a bone protruding through the skin, okay, that is an open fracture. But it can only be definitively diagnosed in X-rays taken at the hospital. So if you have a patient that no deformity, swelling, discoloration, patient has loss of motor sensory distal to that site, don't document fracture. Okay, just document what you see. Patient has, swell to the, around the lower extremity, discoloration, bruising noted, motor sensory compromised. Document what you see, because technically when you document fracture, that is considered, a diagnosis, and we don't diagnose as EMTs. Okay, so when you are in your secondary assessment, check for deformities, contusions, tenderness, swelling, and discoloration. Check the skin color, temperature, and condition, as well as circulation distal to the injury site. So with that, I've had a patient with a broken femur, and I can tell you his leg distal to the fracture was like ice cold and extremely pale. Okay, and I was comparing, sites. We were down in like near El Centro, and it was like 100 something degrees outside. So I'm like, all right, well maybe his other leg's ice cold. Checked his other leg. His other leg was fine. What does that tell you? That tells you that fracture is causing an issue with circulation. Okay. Now, when you do have issues with circulation, that is one of those times, where you can realign that extremity and return it to anatomical position. So make sure you're assessing, because as an EMT, there are some things that you can do. All right, other signs and symptoms here: bruising, pain, swelling, deformity, tenderness, grating. So that's where you have the bone on bone, like grinding against one another, exposed bone ends, and then a joint locked into position. All right, now this is the big one. I've seen this multiple times on exams, so make sure you guys commit this to memory here. Okay, the 6 P's are going to be one of those things you will look for bone and joint injuries. So you have pain, obviously pain at the site. Pallor, the skin is going to be pale or can be pale. Paralysis, the patient is going to lose the ability to move the extremity. Paresthesia, the patient is going to have that pins and needles feeling. Pressure, the patient is going to feel like there's pressure in the extremity. And then pulses, so check your pulses, because your pulses could be compromised. Now, I can tell you that fractures present differently. I have broken both of my arms at different times. And I can tell you that both of them presented with very different symptoms. Okay. One was extremely painful. I could feel everything. I could move my fingers. Okay. Now I was younger. I wasn't like, all hip on medical stuff. I didn't even think to check pulses, but I could tell you it hurt. I felt every little bit of it. I could feel my hand. I can move my hand just fine. Everything, it just hurt like all heck. I had a fractured radius ulna. Now, I broke my other arm. Same kind of fracture. Okay. That one, could not move my fingers. My hand was like numb, or kind of had that feeling like you fell asleep on it. Okay. And it didn't hurt. It didn't really hurt at all. It just felt like I had some pressure kind of in that area, and that was it. So they do present differently. Now, those are just the difference between my right and my left arm. but they presented differently with signs and symptoms. And that's why we really can't diagnose. We'll just, if we have a patient where we suspect fracture, we treat it the same. So getting into our treatment. Okay, so make sure you're using your standard precautions. Wear gloves, minimum amount of PPE you're going to wear on every single call. Maintain inline spinal stabilization. That's if clinically indicated. There is a mechanism of injury that supports inline stabilization. Make sure you take it. Focus on your life threats first. Administer oxygen if clinically indicated. Maintain that airway. Control any life-threatening bleeding. And now we can get into splinting the bone or the joint side. All right, so with splinting, I know I'm probably going to get a little bit ahead here. I'm sure you guys have probably done this in skills a bit. So with splinting, if you have a long bone fracture, we'll use the radius and ulna as an example. If you suspect a fracture there, you need to stabilize the joint below and above the fracture. So when I am applying my splint, and this is something you guys should be doing in skills, your splint should be immobilizing the wrist, and then that long bone, and then the elbow. All right, that is how your splint should be established. Okay, so wherever that fracture is, so let's say the humerus. All right, so I should be able to immobilize the humerus, I should immobilize the elbow, and I should immobilize the shoulder. All right. Make sure we're checking CPMS, so cap refill, pulse, motor sensory, before and after we apply our splint, because we want to make sure we don't cause any damage by our splint application. And then apply cold packs and elevate the extremity. Okay, cold packs can help with pain. Okay, can help with swelling. Elevating the extremity helps with swelling. Okay, then we'll repeat our vital signs, check our interventions. Checking our interventions meaning check our splint, check cap refill, pulse, motor sensory. All right, make sure that we're not causing any additional damage. Okay, guys, improper splint application can be detrimental to the patient. Okay, if you've applied a traction splint on the patient, you should be rechecking traction and make sure that you have the adequate amount of traction applied. I can tell you, I didn't use the Kendrick traction device. It's a North American Rescue. It's one I've been issued from the military, but they're the same exact thing, pretty much, from the Kendrick traction device. It's the one that goes together like a tent pole that you guys hopefully are using in skills. With that splint, I had a patient with a mid-shaft femur fracture, no other involvement. I did not have medications to adequately, deal with this patient's pain where we were at. And it was hard to manage because we had the traction splint applied, and he had so much muscle contraction occurring in that he actually caused the tent poles to kind of bow out, and his leg would laterally rotate, and it would get shorter. And so we would have to continually reassess and to make sure our traction was adequate, because when those bone ends are grinding against one another from his muscle contractions, it's just causing more pain. And every time that would happen, he would get an excruciating pain. Okay, so splints are used to prevent movement of dislocated joints or bone fragments or ends. Okay, we're using these splints to help reduce movement, to reduce further damage. Remember, unstable fractures are going to move and they're going to damage tissue. Okay, so we want to stabilize those bones, okay, so we don't have any damage to surrounding tissues. Hopefully, immobilizing those bones will help reduce pain and then reduce the chance of complications such as severe blood loss, nerve damage, okay, things like that. Now, here are complications. So muscle, nerve, and blood vessel damage. Remember those sharp bones moving around, okay, like little knives in there. Conversion of a closed fracture to an open one. Restriction of blood flow, excessive bleeding, increased pain, and paralysis of extremities, so spinal injury. All right, so these are some of our complications, and this is why proper splinting is so important. Now, with our general rules, assess CPMS, so cap refill, pulse, motor, and sensation. So cap refill, adult patient, cap refill should be less than 2 seconds. Okay, kids should be less than 2 seconds. Females less than 3 seconds. Geriatric patients less than 4 seconds. Okay, that's your normal cap refill time. You should be checking that. Pulses, are they present? Okay, do you feel them? Okay, motor, can the patient wiggle their fingers? Can they grab your fingers? Okay, are they able to move? Sensation, do they feel you touching them? Make sure you're assessing that before and after your splint application. Immobilized joints, both above and below. So again, radius ulna fracture, we should be immobilizing wrist, immobilizing elbow. Tib fib fracture, we should be immobilizing the ankle, should be immobilizing the knee. Cover all wounds, align injured limb if needed. So again, EMTs, you guys can return a deformed extremity to anatomical position if they have compromised circulation. Okay, if they have compromised motor sensory. Okay, so you have one attempt to do this, but attempt to return it to anatomical position and then reassess. Okay, if you do not have pulses, so let's say you've assessed the patient, pulse was absent, all right, and it's all deformed. You then decide, okay, I'm going to return the leg to anatomical position. You assess pulses. Hopefully they're back, but if they're not, that's it. You only have one chance to get that pulse back. All right, so just return it to anatomical position. If it doesn't work, then just splint it and then move on. If you try to realign the extremity and it causes excruciating pain, okay, or you're getting a lot of resistance, and that's it. Don't try to realign it. Just splint it position and then move on. Now, pad your splints. Okay, some of these, have padding with them. Sometimes, you may have to just use cardboard splints. Make sure you're applying an adequate amount of padding because you don't want to create pressure points. Hold traction stabilization until the splint is applied. Okay, when in doubt, splint. Remember, if you suspect it, it doesn't matter if it ends up being, just like a muscle strain or a sprain. Just splint it, and then they go to the hospital. Worst case, they're gonna, take the splint off. Versus you not splitting it, and then you go there and come to find out they have a horrible fracture, and because it's been unstable, it's been causing more damage, and then ultimately treat for shock. So if you have a patient that's in shock, high flow O2, supine position, keep them warm, transport immediately. All right, we have different types of splints. So we have rigid splints, in a sense, like cardboard splints or rigid splints. Pressure or air pneumatic splints, that's where you put air into them. Okay, they become stable. Traction splints, like your Kendrick traction device, your Sager or hair traction devices. Your formable splints, that's going to be like the SAM splint where you can mold them. Vacuum splints are ones where you can take the air out of them and then they become rigid. Sling and swath splints. Sling and swath is something you make with the triangular bandages, mainly for like stabilizing an arm. Okay, spine board or full body vacuum mattresses. Here's something that's great, guys. Your backboard is a gigantic splint. So if you have a critical patient that has trauma from their feet all the way to their head and you're managing those life threads, guys, a backboard is a great way to stabilize, all of those broken bones, and then focus on your life threads and then transport the patient to your trauma center. And then you have your best type of mobilization devices, or like the Kendrick extrication device. We got some pictures coming up here. All right. So traction splint, like an improvised splint right there, air pneumatic splint. Here's another traction device there. It looks like your Sager, your rigid splint, and then your backboard. Here's your bipolar traction splint. We have skills that dedicate time to this. This bipolar one, just remember this is one where you actually need to pull manual traction on the extremity first and then you apply your S hook and then begin to tighten the winch. Whereas the Sager splint, you're pulling your traction with the Sager device itself. All right, here's an example of an improvised splint. Now, guys, with your splints, okay, it doesn't have to look pretty as long as it's doing the job. So this is enough to provide enough rigidity to stabilize the bone. All right, or if this is like an ankle injury, it's stabilizing this ankle and then the tarsal bones and then that long bone coming off of it. All right, so it doesn't have to be pretty as long as it works to provide stabilization. This is nice and soft. Okay, so we don't have to worry about pressure points here. Now, issues with improper splinting. Now, that's where we deal with compression of nerves, tissues, and blood vessels, delayed transport. If we're getting so sucked into splinting the patient's, tib-fib fracture that where it takes time and he should be a load and go, quickly get to the hospital, that can cause issues. Reduced distal circulation. So if we apply a splint that's maybe too tight, it could start to have a tourniquet-like effect, especially if we have a lot of swelling going on. And then if we use like an ACE wrap that compresses, that can cut off circulation. Aggravation to the injury, excessive motion with applying the splint, and skin damage from improper padding, so creating those pressure points. Now, with splinting long bone injuries, so test pulse and motor sensory function. So make sure you're checking that before you've applied a splint, before you've done anything, like before you try to realign, anything like that. Check CPMS. Align if needed. Do not release traction until it's splinted. And then splint in a position of function. Okay, so like the hand is a great example. We do not want to splint the hand in like a fist position, or we don't want to split the hand like fully extended out. We should keep the hand in like a relaxed, think like a Lego hand type position, if you will, just in a position of function. Okay, then reassess CPMS after the splint application. Okay, now with splinting ligaments holding the bones in proper position are often stretched or torn loose. Signs and symptoms can be the same as fractures. Okay, assess pulse and motor sensory functions below the injury, and oftentimes we're going to be splinting these in the position found. Okay, so splint these in the position found because we're not trying to reset any dislocations. All right, traction splints. Now, your traction splint, if you guys remember your contraindications for this, we kind of have a narrow window for when we can use this. So we have a mid-shaft femur fracture with no other involvement. So it needs to be mid-shaft, can't be close to the knee, cannot be close to the hip, okay? Cannot have any damage to the knee, tib-fib, ankle, okay? Can't have any injury to the pelvis. All right, so isolated mid-shaft femur fractures. Now, this traction splint is great in that with a femur fracture, there's a risk for blood loss. So femur fracture will pull those muscles tight by applying that traction, and it can help with hemorrhage control. I can tell you, I have applied traction splints, on real patients. And the one thing that we talk about is, the patient experiencing this, relief. All right, I can tell you, I just have not experienced that, and I know for a fact that we've had adequate traction applied. I'm not saying that that doesn't exist. I'm just saying that that's not my experience. But if you do get relief, then okay, then hold your pull of traction at that point to wherever the patient's comfortable. All right, so do not use a traction splint if the injury is within 1 or 2 inches of the knee or ankle. Knee has been injured, hip has been injured, pelvis has been injured, or there's a partial amputation or avulsion. In a sense, you do not want to make a partial amputation a complete amputation. So mid-shaft femur fracture, no other involvement. That's where we can use traction splint. All right, now With splinting, so special techniques can be applied to splinting of suspected bone or joint injuries to specific sites. Uh, and this is all going to be, that's more skills focused, but splinting a pelvis. You do not need a fancy commercial pelvic binder in order to provide stabilization to a patient's pelvis. You can, use the linen that you have on the ambulance and use just a simple knot to try to stabilize, wrap around the pelvis and to stabilize it. I've improvised SAM splints and tourniquets into pelvic binders. It's just you're limited to what you have in your imagination, but you want to achieve the goal of immobilizing the injured bone and then the joint above and below that side. All right, so pelvic fractures. So associated with pain and significant bleeding. I've had patients with broken pelvises before, like a lot of pain, a lot of pressure in the lower abdomen was the biggest complaint. Make sure you're checking distal function of both lower extremities on that patient. So hey, check pulses down low to see if there's any issues with blood flow. So there are commercial pelvic binders that are out there. I gave you guys a couple examples of improvised splints, like sheets. I've made SAM splints and tourniquets work for a pelvic splint. And then we also have the pneumatic anti-shock garment. The pneumatic anti-shock garment is think of it like a giant blood pressure cuff for your lower body. Okay, so it wraps around the legs and the pelvis, and then you pump it up, much like you do a blood pressure cuff. It was something used for shock patients in order to promote perfusion to the upper body, because it pulls all that blood, pushes it all up to your upper body. Um, but it can be used to stabilize a pelvic fracture. All right, here's an example of a commercial pelvic binder. Now, compartment syndrome. So compartment syndrome occurs when you have damage to, muscle that's surrounding an area. All right. So as that like say you have, let's just say a big box falls on your arm and it damages the muscle around your arm and your arm hurts. Okay. Well, those muscles are going to start to swell within their capsule. You have small blood vessels that are going through those muscles. And as the swelling gets worse and worse and worse, what happens is it compresses those blood vessels, creating inadequate blood flow to provide oxygen and nutrients to the tissue, and then remove the waste products. So the muscle in that area becomes hypoxic, okay, which starts to release lots of lactic acid, which causes damage to the extremity. Okay, and people can lose extremities from compartment syndrome. The extremity may get really hard to the touch. The patient may have like a burning sensation like pain. All right. But that's one thing that is a big concern with musculoskeletal trauma is compartment syndrome, and there's not a lot that you can do as an EMT for that. Applying ice to reduce swelling and then transporting the patient to the hospital. All right, so your signs and symptoms of compartment syndrome are going to be severe pain or burning sensation, decreased strength in the extremity, paralysis of the extremity, pain with movement. Extremity feels hard to palpation, so it's hard to the touch. Okay, distal pulses and motor and sensory function may be normal, so they might have adequate CPMS. But if you have that area that's inflamed, hard to the touch, suspect compartment syndrome, and that is a condition where you need to take that patient to the trauma center. All right, now pathological fractures. So these are non-traumatic type fractures, and this is in patients who have like bone disease. Think osteoporosis. All right, these are patients. You have patients that bones are so brittle that just mishandling them by moving them in bed could cause fractures. All right. Now, with this you see this in patients with history of cancer, osteoporosis, bone conditions like congenital cysts. These patients all suffer pathologic fractures. All right, where it does not take a lot to cause a fracture. At the end of the day, you're still going to treat that like you would any other fracture, where you're immobilizing, CPMS before and after, transporting the patient. Okay, so that concludes this class, guys. A couple things, make sure you know your bones. It doesn't necessarily apply with this class, but chapter 7, because you guys are going to be getting questions on that, all over the place on your bones. Make sure you know the different types of muscles, cardiac, smooth muscle, skeletal muscle. Make sure you know those and know something about them. Know ligaments connect bone to bone, tendons connect muscle to bone. Okay, go over your 6 P's. All right, pain, pallor, pulses, paresthesia, paralysis, pressure. Okay, know your 6 P's dealing with musculoskeletal trauma, because that's another big one that you're going to be seeing on exams, like knowing your signs and symptoms. Okay, that concludes this class. Thank you for your time.